Hello everybody, this is Carlos and welcome to another video. In today's video, we're going to go over temporary pacemakers, and this is intended to be a guide for nurses and nursing students. The pacemaker model that we'll be using in our discussion is the Medtronic 5392 with the software version 00.09.00. Now, some of the learning outcomes by the end of this presentation will be that learners will be able to indicate the reason for pacemakers, have an understanding of pacemaker terminology, including pacing, capturing, and sensing, display knowledge of the NBG code, and also the most commonly used pacing modes, identify some of the pitfalls of the pacemaker, and also implement some nursing safety strategies and documentation. Now, just so we can get this out of the way, in Ontario, where I am from, we do have the Regulated Health Acts that it governs what are some of the actions that nurses can do. So in Ontario, the Control Acts that we have, it prohibits registered nurses and registered practical nurses from applying any form of energy or prescribing it. The only nurses who can perform this Control Act are nurse practitioners. So please check with your local jurisdiction to see if there's similar legislations or regulations. Now, some of the indication for pacemakers. Pacemakers are usually used for patients who have symptomatic bradyarrhythmias, meaning that their heart rhythm is too low, leading to the patient not feeling well or being hemodynamically unstable. Some of the bradyarrhythmias include symptomatic sinus bradycardia, second degree type 2, a complete heart block, junctional rhythms, or idioventricular rhythms. Now, pacemakers, generally there's two types. There's the temporary and the permanent. Permanent are the ones that are implanted into the patients for a long term, and the wires of the pacemaker are internal, and also the machine is internal, and they're usually visible under the skin for the patient when we do our assessments. The temporary pacemakers, there's two types. There's the transcutaneous pacing, which is more for our emergency pacing. These are the ones that we use the pads from our defibrillator, and the pads from the defibrillator, aside from the ability to defibrillate, they can also pace. The only trouble is that because the electricity needs to go through the skin, the bone, the fat, and the muscle before it reaches the heart, we need a higher amount of energy. And if the patient is still awake, it could be quite uncomfortable for them. Transvenous or epicardial pacing, this is the one that we'll be focusing more in this talk, includes that the wires are internal, either they are on the epicardium or inside one of the chambers of the heart, depending on which one it is, but the machine is external. The one we'll be discussing will be a dual chamber generator, as the Medtronic it is, and also the modes that we're going to discuss include on demand, or we call it synchronous, or the asynchronous or a fixed mode. So some of the terminology for pacemakers include pacing, capturing, and sensing. So pacing or firing is just the pacemaker delivering an electrical impulse. Capture means that once the pacemaker has delivered that electrical impulse, right, the atria or the ventricle should contract, also known as they should depolarize. Sensing is just the pacemaker's ability to see the patient's intrinsic heart rhythm, either the atria or the ventricles or both, depending on which mode of pacemaker we use, and is intended for the pacemaker to not fire when it's not intended to, and to fire when it's supposed to. Okay, which brings it to the two modes. So on demand is as needed. The pacemaker starts pacing only if the heart rate falls below the number that we set in the pacemaker. Asynchronous mode just means that the pacemaker will start pacing regardless of whether the patient has an intrinsic rate or not, meaning that in asynchronous mode, the pacemaker is not going to sense, it's only going to pace. Okay. The two types of energy that we have in the pacemaker that we should be aware of include the milliamperes, milliamps, and the millivolts. One way to remember them is that milliamps has an A, and this is the energy needed for capture, and capture also has an A. Millivolts, on the other hand, it's the amount of energy needed for the pacemaker to see. Okay, sensitivity. And sensitivity is the word that has a V in it. Also, since this is needed for the pacemaker to see, vision. That's another way for you to remember the millivolts as opposed to the milliamps. Now let's go through the basic ECG wave. So the ECG wave include the P wave, the QRX complex, and the T wave. The P wave right here is the atrial depolarization, meaning the atria contracts here. The QRX complex right here is where the ventricles depolarize, meaning the ventricles contract, and the atria relax. Because the ventricles are so much bigger than the atria, it completely overshadows the atria wave. But it is understood that the atria relaxes inside the QRS, okay, while the ventricles contract during the QRS. And the T wave is the ventricular repolarization. Again, this is where the ventricles relax. Which brings us to pacing or firing. And like we said before, it is the delivery of an electrical impulse by the pacemaker machine. As you can see over here, it is denoted by this little thunderbolt. Every time when the pacemaker fires or paces, it will create a pacing spike, right? And one principle in cardiology is that electrical always comes before mechanical, meaning that there must be electrical stimulation in the heart before the ventricles or the atria can depolarize. And this is a principle that we can definitely see in the pacemakers. As you can see, the pacing spike electrical always will come before a mechanical depolarization, okay? And it's so that we should talk about some of the chambers that are being paced. In here, we call the atrial pace or A pace. And as you can see, the pacer fires, as you can see in all of these little tiny thunderbolts, and it fires always before the atria. Okay, so because it's only atrial pace. And back to our principle that we talked about, that electricity must always come before mechanical contraction, and we can clearly see this here. The pacemaker fires, for example, here, and is followed by the atria depolarizing or contracting, and it's quite regular, as you can see it over there. On a ventricular pace or V pace, it is similar, but instead of pacing the atria, we're pacing the ventricles, okay? And as you can see here, based on our ECG wave that we talked about earlier, that the QRS is where the ventricles depolarize or the ventricles contract, we can clearly see here that when the pacemaker fires here, the ventricles follow up with a contraction. Right, so this one here, it's a ventricular pace because it happens just before the QRS. The previous slide here, this one is atrial pace because it happens just before the P wave. Okay, which brings us to our dual pace, and sometimes we call them AV pace, meaning atrial and ventricular pace. And in here, you can see that we just mix both the atrial and the ventricle pace together. So the pacemaker is gonna fire before the atria, and the atria depolarizes, and then it's gonna fire again before the ventricle, and the ventricle depolarizes. So in this mode, both chambers are being paced, as you can see over here. And the same principle applies. Electricity comes first, followed by a mechanical contraction. Now, pacing or firing, like we said before, it is the ability of the pacemaker to initiate an electrical stimulus. Some of the issues that can happen is failure to pace, meaning that the pacemaker does not fire or fails to produce an electrical stimulus when it should. So some of the solutions include: first, check the patient, make sure the patient has a pulse. If the patient does not, call a cobalt and call for help. We should check the battery, make sure that there is enough battery and the batteries are installed properly, otherwise change the battery. Check the cables and the connectors, make sure they are fastened and connected securely and properly. If after all of that the pacemaker is still not working, change the pacemaker machine to a new one because the machine could be defective, and always have help readily available should the patient condition change. Now, capture, like we mentioned earlier, it is the ability of the atria or the ventricles or both, depending on which mode, to depolarize after the pacemaker has fired. And it is based on the principle that the higher the power, the higher the chance of the ventricles or the atria from depolarizing. In this example here, as you can see from the bottom, the pacemaker is firing. And at 3 milliamps, it's capturing, as you can see over here, right? It fires, and there is a the QRS follows it. It fires, and the QRS follows it. So this is a V-pace chamber. If we go down on the energy down to 2 milliamps, it's still firing and still capturing, so that's great. But once if the energy, the milliamps, remember milliamps for capture, right? If it goes low enough, the pacemaker will still trigger the pacing, but then it might not have enough energy to capture the ventricles or the atria. So when that ends up being the case, we call this failure to capture, meaning that the pacemaker is firing, but it's not capturing every single beat. So the solution would be to check your pacemaker, the wires, and the battery. And because the ventricles or the atria or both are not depolarizing after the pacemaker goes on, maybe the milliamps is not enough. So the solution would be to try to increase the milliamps until we see capture in our ECG. Now, the principle of sensitivity is the ability of the pacemaker to see the patient's own intrinsic heartbeat. Okay, and the principle of sensitivity is based on the idea that the lower the millivolts, the more the pacemaker can see. The higher the millivolts, the less the pacemaker can see. If you can see from this little image here that we have here, 1.5 millivolts is higher than 1.0, which is higher than 0.5. So at 1.5 millivolts up here in this line, right, the pacemaker cannot see anything below 1.5, because if you cover, for example, imagine that you put a piece of paper at 1.5 millivolts, it will cover everything below it, so the pacemaker cannot see anything. The only way for us to have the pacemaker start seeing or sensing some of the patient's intrinsic heartbeat is to lower the millivolts. So if you lower the millivolts to 1.0 in this line right here, again, do the same experiment, put a piece of paper and cover everything below 1.0. In this case, we're going to see that this spike, this QRS, the pacemaker is going to be able to see this QRS from the patient, but still not seeing enough. So as we keep going lower to 0.5, to this line right here, let's do the same experiment. Put a piece of paper and cover everything below 0.5, and then you can see that the pacemaker can see everything above 0.5, right? You can see this spike right here, you can see this spike, and you can see this spike. And that's a principle about sensitivity. Let's use this analogy. Imagine that the house at the back is the patient's intrinsic heartbeat, okay, and the fence is the sensitivity of the pacemaker. Now, in this example right here, as you can see, the fence is very high, meaning that we cannot see the house behind. We cannot see the patient's intrinsic heartbeat. One way for us to fix this is to lower the fence, right? So if we cannot see the patient's intrinsic heartbeat, then we need to lower the millivolts to increase the sensitivity. And the opposite is true. If we're seeing too much of the house, or we're seeing too many intrinsic heartbeats from the patient, right, then we need to filter through some of the things that we want to see, because we don't need to see everything. And in this example, what we'll do is we will increase the millivolts, right, or we will increase the fence so that it covers certain part of the house that we don't need to see everything. And that is the principle of sensitivity. Which brings us to two of the problems of sensitivity. One is undersensing and one is oversensing. Undersensing is just the pacemaker cannot see the patient's heartbeat, intrinsic heartbeats well enough, and therefore it starts pacing repeatedly because it thinks that there is no heartbeat. So the pacemaker starts to panic a bit and starts to just fire randomly. And one of the solutions is to check the pace leads. And like we said before, if it's undersensing, meaning that if the pacemaker cannot see, meaning that the fence is too high, right? Then one solution will be to lower the millivolts or lower the fence, as we can see over here. Okay, so if the pacemaker is not seeing the heartbeat, the intrinsic heartbeat well enough because the fence is too high, we need to lower the fence. We need to lower the millivolts, and that is undersensing. Oversensing is the opposite. Oversensing is the pacemaker sees too many intrinsic beats, or it thinks it sees intrinsic beats when they're really not there. For that reason, it's hesitant in going off, right? Because it's not sure if that is a patient's intrinsic beat or not, but then the pacemaker, because it's too sensitive, is going to be on the safer side. The issue with this is that the patient will have reduced cardiac output because the patient will be missing quite a few heartbeats. And if we look at our analogy from here, then it will be this house on the left side here, right? We're seeing too much of the house. We're too sensitive. We see too much. So one of the solutions would be to raise the fence or raise the millivolts, right? So then when we do that, we will be able to filter through some of the things that we want to see and the things that we do not want to see. This is an example of how undersensing it is. So as you can see over here, the pacemaker fires, and it fires randomly anywhere in the ECG. So as you can see in this example, the pacemaker fires right before the QRS. In here, it fires right on the T. Here it fires right on the P. So then it becomes problematic because one of the biggest things and the dangerous things of undersensing is what we call this phenomena called an R on T, meaning that the R wave happens in the ECG when the T wave is supposed to happen. So if you recall from the earlier slides, the QRS is when the ventricles contract, right? And the T wave when the ventricles relax. So in this phenomenon, when the ventricles is supposed to relax, then it contracts instead, right? So as you can see in this example over here, P, QRST, okay, that's okay. P wave, QRS, and this is supposed to be a T. So here is supposed, the ventricle is supposed to relax. But if the pacemaker, because it's not sensing properly, accidentally fires on the T wave, it can throw the patient into ventricular arrhythmia, which could be very dangerous if not lethal. Now the opposite is oversensing, okay? So some of these examples you can see over here is that the pacemaker thinks it sees intrinsic beats when they're not there. In the first example on the top right here, right on this beat over here, the pacemaker feels that this here was a patient intrinsic beat. And because it thought that it was an intrinsic beat, meaning that it was way too sensitive to it, right? Then it didn't fire. And because it didn't fire, there was no capture. Same thing with the example in the bottom here. Here, you can see that the pacemaker fires, right, and it depolarizes. Here it fires and it depolarizes. Here, after the P wave, the pacemaker is too sensitive. It thinks that the patient has a ventricular, an intrinsic ventricular beat. Therefore, the pacemaker was hesitant in firing, and therefore it did not fire, and there was no capture. And as you can see over here, right, the patient will be missing one beat. And if this occurs very regularly, you can actually see how the cardiac output will be significantly lower for these patients. Now let's talk about our NBG codes. It's denoted by 3 letters. The first letter is for pacing, second letter is for sensing, and the third letter is for the response, okay, to the sensing. The letters that we have for pacing, as you can see in the legend, A, V, D, A for atria, V for ventricle, D for dual, meaning atria and ventricle. The sensing, same thing, atria, ventricular, dual, and then we have the O. O just means don't sense. One way you can remember is O, 0, 0, do nothing. Okay, response. We have, for the response, we have I, which is inhibit. Okay, inhibit just means as on demand, as needed. Trigger is to trigger response. Dual just means inhibit and trigger. And O just means don't respond. Again, 0, do nothing. Now let's go through some of our common pacemaker modes. In AAI, okay, this mode here, if we enter this mode into AAI, the pacemaker will think, okay, I'm in AAI mode. I will sense the atria, right? If I see the patient has his own atrial rhythm, I will not pace. I'm inhibiting that, right? However, if I do not see the patient's own atrial rhythm, then I will pace and fire and try to capture the atria as needed. So this is what this mode means. VVI is similar to AAI, except that it's for the ventricles. So we put VVI mode onto the pacemaker. The pacemaker will start thinking, okay, I will sense the ventricles, right? If I see the patient's own ventricular rhythm, I will not pace. I'm inhibiting. However, if I do not see the patient's own ventricular rhythm, then I will pace and fire an electrical impulse at the rate that you tell me. We're pacing the ventricles. Okay? Which brings us to the next mode, which is DDI. So DDI, if we input this mode into the pacemaker will think, okay, I will sense both because D is for dual, atria and ventricle. Then if I see the patient on atrial rhythm, right, I will not pace the atria. Okay, great. Now, if I see the patient on ventricular rhythm, I will not pace the ventricle because it's dual, atria and ventricle. However, if I do not see the patient's either the atria or ventricular rhythm, right, then I will pace either the atria or the ventricle or both at the rate that we set in the pacemaker. Okay, so this is what this mode here means. It just mixes AAI and VVI together. Which brings us to an even more common mode that we use, which is triple D. Now, triple D is slightly similar to DDI with one key exception. So if we put DDI mode into the pacemaker will think, okay, I will sense both the atria and the ventricle because it's dual sensing. Then if I see the patient's atrial rhythm, I will not pace or fire. If I see the patient on ventricular rhythm, I will not pace and fire. Okay, so far is the same. However, if I do not see the patient on ventricular rhythm, I will pace the atria or the ventricle or both as needed. So far is identical to DDI. Now here comes the difference. The difference is that DDD, this mode here, is what we call a tracking mode. It tracks. DDI, the previous one, it is what we call a non-tracking mode, meaning that the atria and the ventricle pacing could be independent of each other as long as if it drops below the rate that we set in our pacemaker, they could be paced separately, okay, at the base rate that we have. Now in triple D, it is, or DDD mode, it is a tracking mode, meaning that the pacemaker will always check on the atria first. If the atria depolarizes, right, either because it is the patient's own beat or because the atria fell below the rate that we set in the pacemaker, then the atria will be paced. Now, once the atria is paced, either because the atria went on by itself or the patient intrinsic beat or the pacemaker went on, then the machine will give the ventricles a time window to depolarize, okay? If the ventricles depolarize within this time window, then the ventricles will not be paced. However, if the atria fires and then the ventricles do not depolarize within this time window, then the pacemaker will also pace the ventricle at that point. And this time window is called the AV interval, which is one of the settings that we must check in the pacemaker on the bottom screen. Okay, this mode here, the ventricles always have to check up with the atria because they need to keep up with the atria. And also one of the biggest differences, because the ventricles need to check up with the atria, if the atrial beat is faster, because remember the atria, that's where we have our SA node, which is our normal pacemaker in the body. If the atria is going at 80 beats per minute, for example, right, the ventricles can actually be paced faster than the rate that we set in the pacemaker because it needs to check with the atria. Okay, and this is where the AV interval here comes in very important, because if the ventricles do not depolarize within this time window, then the pacemaker will also pace the ventricles, and because of this, the ventricular rate can be higher than the rate that we set on the pacemaker. So that's one of the key differences between DDI and DDD. Okay, which brings us to our asynchronous mode, okay, which is DOO. So if we put DOO into the pacemaker, the machine will start thinking, okay, I will not sense any chamber, right? O, 0, do nothing. So sensing nothing. I'm not going to sense neither the atrium, neither the ventricle. I will not respond to any atrial or ventricular stimulus, meaning that response, 0, don't respond. I will pace at full power at the rate that you tell me, because we are pacing the first letter, right? We're doing atrial and ventricular pacing. That's why this mode here, we call it asynchronous. It's the mode that only paces at full power and it does not sense at all, okay? Now let's go through some of the safety checklists that we have. Now the first button on the top here of the Medtronic pacemaker box that we're talking about, this is where the DOO mode is, our asynchronous mode. Okay, and the asynchronous mode is used usually in two cases. One, if there's a magnet involved, or if there's any sort of magnetism involved. For example, if the patient needs to go for an MRI, right? Because magnetic waves interfere with sensitivity, which is why this mode, since it turns off sensitivity, then we can only focus on pacing the patient during, for example, the MRI. Okay, and it's also important for patients who are pacemaker dependent. If the patients are pacemaker dependent, meaning that if we do put the pacemaker on standby and the patient heart rate drops to 20 beats per minute, right? That means that the patient needs the pacemaker, and this is one of the modes that we will put the patients on. On button is right here. This is the on-off button. Number 3 here, the little key is in order. This is what you will use to lock your machine, okay? And number 4 is the enter or confirm button. So some of the default settings that you should be aware of is that if the machine gets turned on, it will automatically default into these settings, which is mode triple D with a rate of 80, atrial output of 10, ventricular output of 10 milliamp each, and the sensitivity of the atrial is 0.5 and ventricular sensitivity is 2.0. Nurse practitioners or the doctors, they can change these settings. This is just the default settings that if the machine gets turned off and turned on, these are the modes that will populate by default. So keep that in mind. Which brings us to the DOO button. So once the DOO button, the asynchronous mode is pressed, there is a mode that the pacemaker will go on. So the rate is at 80. Okay, the atria will be paced at 20 milliamps, which is maxed out, as you can see here from the dial right here, and the ventricle is also going to be paced at max power here, which is why this is the mode that the pacemaker is going to pace at max power and it's not going to sense. Okay. Now, what will happen if we accidentally press the DOO button or the patient activates it by accident? Okay, so first, do not panic. First thing you should do is stay with the patient and do an assessment, including your vitals, head to toe, and pain assessment, and also to see if assess for a clinical presentation of the patient. Next, you're going to call for help. Either you're going to press the call bell or you're going to ask one of your colleagues to come and give you assistance. Or have them, which leads to number 3, page the physician or page the NP to let them know that the DOO mode was accidentally activated, either by the patient or by yourself or whatever it is. And number 4, always have an emergency equipment on the bedside, because just in case that the patient goes into arrhythmias, you will have a defibrillator at hand to intervene should that be the case. Now, some of the safety checks that we're supposed to do, and this is pertaining to the EPIC documentation system. EPIC is a very it's a robust system and is quite popular. Not to say that it doesn't have its glitches, but the documentation we're gonna be discussing is a little more EPIC focused. Okay, the principle behind, regardless of which documentation system you use in your own hospital, the some of the setting that you will be documenting will remain exactly the same. It's just that for this demonstration, we're using EPIC. Okay, so your orders will be under the nursing order tab. And in here, for example, I entered some epicardial pacemaker settings just for the example. And one of your roles as a nurse will be to check your orders, the settings, and make sure they match the settings in your machine. Okay, you do not change settings, you do not touch any of the dials and everything, because again, it is not within the responsibility of the nurses to do that, at least in Ontario and in the inpatient wards. Okay, but please also check with your institution. But for the purpose of this talk, we're gonna go over the checks of it. Okay, so the rate 60 right here, check. Mode triple D right here, right beside the battery indicator. And since we're talking about the battery indicator, which has 5 bars, right? You're gonna change the battery if the bars are 3 or less. Okay, ventricular output of 10, ventricular output 10, great. Then we have ventricular sensitivity of 2, sensitivity 2 right here. Atrial output of 10 milliamps, there it goes. Atrial sensitivity 0.5 right here. And because this is a DDD mode, we do have an AV interval, right here, which is 170 milliseconds. Okay, and these are the checks that we need to do for our pacemakers every shift. Okay, which brings us to the batteries. Now the batteries, the machine has an internal battery and also has external batteries. The external batteries are AA batteries, and once the machine is on and you press this little button at the bottom, this set here will pop out and you will have about a minute and a half. The machine will stay on, that the battery, the internal battery will last. But be mindful that that is also dependent on the age of the machine, right? And also the how well maintained are those batteries. For that reason, try to replace the batteries within 30 seconds to 1 minute. Okay, if you put the batteries in the wrong orientation, the battery indicator right here, okay, will blink red. If it's red, you know that there's something wrong, so please double check on that. All right, and also when your batteries are popped out like this, the battery indicator will also blink red. Let's talk about some of the pitfalls that this model has. Pitfall number 1 is a single press on button, meaning that if you have a patient that has an order for the pacemaker to be turned off, but the wires to still be connected to the pacemaker, because the patient has not have any arrhythmias in the last 24-48 hours, they're hemodynamically stable, and they're doing well, right, as one of the precursors for discontinuation of our temporary wires. Then one of the pitfalls of this machine is that if you press the on button once, it will go on into our default mode that we talked about earlier. Which brings us to also another pitfall here, the DOO button at the very top, the asynchronous mode. It is also a single press button. Okay, potential dangers of this could be that this button could be accidentally pressed, okay, and then the patient will be paced at atrial pace of 20, ventricular electricity of 25, so atrial output of 20, ventricular output of 20 milliamps, and a rate of 80. So please keep this in mind, because this could potentially cause some patient harm, especially if the patient is thinks that this machine is a call bell, right? If they're pressing a call bell, no one comes, and they start to think, or if the patient is a little confused. So there's many different situations that could be might not happen as often, but then you don't want to take that chance when it does happen. So let's talk about some strategies to mitigate this. Strategy number 1, if possible, please hang your temporary pacemaker machine on your IV pole outside of the reach of your patient. Okay. Number 2, make sure you press the key button here to lock the pacemaker whenever after you do your checks. Okay, now one of these, even though this is a safety strategy or features that this machine has, as you can see here from the bottom screen, it's very easy to unlock, because it just says that press the key to unlock, and our patients are very smart, right? So please keep that in mind, because locking it is a safety, but also to unlock it, it's not that complex at all. which brings us to the third one, which is the most important one: patient education and family education. Make sure that you let the family and the patient know about the rationale for not touching the pacemaker, the need for the pacemaker, why they have it, and also to tell you if the patient start to feel unwell, if they start to feel pain, or if they just start to feel unwell overall. Okay, but patient education, it's one of the crucial things that will minimize any tampering or playing with the machines. Not to say that the chances will be zero, but hopefully this minimizes it. Now, some hospitals, they might have a box, might have a plastic bag that goes over the temporary pacer as an additional layer of protection, but just be mindful that not every institution has that. Now, the wires that needs to be connected to the machine, they are color coded. As you can see over here, the atria is blue, right, as denoted by the blue sticker, and the ventricles are white right here. Depending on which models of the electrodes that you have, as you can see, the one that I have here, the blue hub, right, connects to the blue part of the atria, and the white hub here connects to the white part of the ventricle. Your institution might have wires that they do not have color hubs like this, but the actual wire themselves, it might be color coded. So make sure they match it, that you put it in the respective color for that. Epicardial wires, okay. If your patient does come in with epicardial wires, they will come out of the surgery with 2 sets of wires about the epicardial, just around the epigastric area there. Now, the 2 wires that are slightly more to the right, those are your atrial leads, as you can see here, because then those are the ones that are pacing the atria, and those ones should be connected to your atrial port, which is the blue one, right? Hence I put atrial lead blue. Okay, the ones that are slightly to the left, those are your ventricular leads, okay, and those ones should be connected to your white port right here. Okay, if in doubt, always ask, and make sure that when you do give report or take reports, that is part of your transfer of accountability as part of the report process. And this picture here, it just shows how the epicardial wires they look. They're very, very thin, and they connect to the wires like this. Okay. And the transvenous wires very similar, but they just look slightly different because the epicardial wire, these ones go on top of the heart, right? That's why they're very thin. The transvenous, these ones go in the vasculature, usually in the femoral site, and they're endovascular. They both sit in the heart in just slightly different places, okay? But also it needs to be connected so that because both they do the same function, which is to pace, to sense, and to capture if there's a need for it. So what to do if one of the wires disconnects? Okay, so as you can see over here for a transvenous wire right here, this core here disconnected, and in here, this one here disconnected. Number 1, check the patient, make sure they're fine, vitally stable, and do an assessment. Number 2, do not reconnect. Okay, so this is something that is very specific to Ontario because of our control acts. Because if you reconnect the core, it is considered an application of energy. This might be different in your jurisdiction, which is why I need you to check with your own jurisdiction. Okay, but for Ontario, in Canada, where I am from, then this is the thing, that we're not supposed to reconnect this because it is considered an application of energy. Page the doctor or the NP as soon as possible, okay, and stay with the patient and have the emergency equipment as needed. Now we have started with our checks with the machine, we moved to the wires, and now we're gonna move backwards to the patient site. On the site, make sure that we also check the dressing, make sure we check for hematomas, active bleeding, any signs of infection, skin around it, and dressing integrity. Now, especially for our transvenous pacers on the site, make sure that you check for hematomas. An expanding hematoma can lead to a vasovagal response where the patient's heart rate and blood pressure can drop significantly, leading to a symptomatic event for a patient. Once a patient is, when you settle down the patient, make sure that you check the ECG, to make sure that it is pacing properly, that it's capturing and is sensing properly. And this is the part that you're going to involve your telemetry nurse. Okay, communication is so crucial in here. Let your telemetry nurse know that your patient has a temporary pacemaker and wires, right? So that the telemetry nurse can keep an additional set of eyes and ears for your patient, if there's any arrhythmia should they happen. In most institutions, the telemetry nurse will be monitoring more than a few different channels, so you can get an appreciation of how their attention needs to be shifted in many places. So giving them the heads up that your patient has a temporary pacemaker, it will definitely enhance safety for your patient. Documentation using EPIC. Again, this is for the EPIC system. If your hospital uses a different system, you will be documenting in their system, but the principles about what to document remains the same. Okay, so for EPIC, your flow sheets, you're going to document all the settings of your pacemaker in the flow sheet. They're usually under flow sheets, under head to toe, and under cardiac. It will kind of all show up in here. And this is how it looks like when you are going to document. Okay, so you can see I just used the epicardial one as an example. Pacemaker, yes, type epicardial. Okay, mode triple D, which is right here. You can find that. Okay, temporary wires, yes, we have the epicardial ones. Wire status, and this one will vary either based on is the pacemaker on, are the atrial bipolar wire, ventricular bipolar wires, are they connected, are they not? So that's the part that you will find out based on your assessment. Okay, for the purpose of this demonstration, I just put something in there so that to show you how it looks like. Atrial output in milliamps 10 right here, right? And you can see that in your pacemaker right here. Atrial sensitivity 0.5 down here. Ventricular output 10 up here. Ventricular sensitivity 2 right here. Pacemaker set of 80 right here. And battery status check, which is this one. Yes, we did, and we checked it. And that is all for this video. I hope that it provided a little bit of clarity. Thank you for watching. See you next time. Bye for now.